Do I have to use? Sure, yeah.
And then if you Good afternoon. I'd like to welcome everybody to today's Health and Adult Social Care. My name is Jo Lawson and I'm the chair of the meeting. Could we have introductions from the panel members, please?
Helen Clay, voluntary co-optee.
Kim Taylor, voluntary co-optee.
We've had apologies today from Councillor Bill Armour and Councillor Darren O'Donovan. Has there been any other apologies?
None received, Chair.
Thank you. I'll move on to the the second item of the agenda, which is the minutes of the previous meeting. We also note that attached to that is a reply from West Yorkshire Ambulance Service that has been previously discussed, and we are happy with the response that they've actually made. Can I move that the minutes...
Move them, Chair.
And a seconder?
I'll second.
Thank you. Are there any declarations of interest? I take that's a no. Is item number 4, admission of the public. All items will be heard in the public domain, and this meeting is being webcast. Is there any public petitions or public questions?
No public questions and no petitions, but we do have deputation.
Yeah. If I can move on then to Dr. Dylan Murphy, who will be giving his deputation to the committee, and you will have roughly 5 minutes.
Right, it's nice to come here today and address the committee. Right.
It's good if we get pull the microphone forward, please.
Pulling this forward, Chair. The whole thing.
Oh, the whole thing. Okay. Yeah, okay. Right, I'm representing Kirklees and Calderdale ME Independent Support Group. And our group supports people with a neurological disease called myalgic encephalitis, which afflicts over 400,000 people in the United Kingdom, with that number rapidly rising due to new diagnostic criteria. Now, 75% of people with ME are women, 25% of people with ME are house and bed bound and need 24-hour care, and over 90% of people with our illness are too ill to work or to study. I took ill health retirement from a teaching job 8 years ago. I should also add as a bit of context, the NHS currently doesn't have the capacity for effectively caring for people with severe ME, many of whom have problems with swallowing food and taking nutrition. Sadly, I don't have time to talk about the death of Maeve Boothby O'Neill due to the failures of the NHS. In July this year, the Department of Health and Social Care published its long-term care plan for people with ME, which complements the 2021 guideline for the care of people with ME from the National Institute of Clinical Excellence, or NICE, which contained 18 separate recommendations for local health commissioners and hospital trusts to implement. It should be noticed that Kirklees and West Yorkshire ICBs have not yet implemented that guideline over 4 years later. In July, the Department of Health issued a cross-agency care plan for people with ME, and it stated that ME is a highly complex, poorly understood and very debilitating neurological disease. It acknowledged that people with ME have suffered years of health inequalities, suffered from widespread stigma and prejudice from health professionals, the media and the general public. And the care plan makes many recommendations to improve the care and quality of life for people with our neurological disease. I want to focus on that part of the care plan which deals with helping improving healthcare for people living with our illness. And there are numerous scientific studies which point out that people with ME experience high levels of functional impairment across physical and mental domains, scoring overall lower in health-related quality of life tests than most of the chronic health conditions, including lung disease and heart disease. I should add that there are no diagnostic tests for ME, nor there are any known drug treatments for our neurological disease. Now, my support group, of which I'm the Joint Campaigns Officer, has been involved in negotiations with the Kirklees ICB and the West Yorkshire ICB for well over a year now. And our objective has been to address the health inequalities which people with ME experience in this area. And in our negotiations with the Kirklees and West Yorkshire ICB, we've called for specialist ME services to be established in this area, which is in line with the recommendations of the Department of Health ME Care Plan, which calls for specialist care for people with ME to be brought closer to home. Currently, there's one specialist clinic for people with ME in West Yorkshire, which is at Seacroft Hospital in Leeds. There's a very, very long waiting list for people to get seen at Seacroft, which has an intake bias towards those people living in Leeds, as was told to me by the clinical lead. If you live outside Leeds and you're lucky enough to get an appointment, then most people across West Yorkshire face extremely long journeys to get to the clinic, which for a fatigue-based illness like ours is extremely problematic. And in our negotiations with both the Kirklees and West Yorkshire ICBs, we've made no progress, I'll emphasise that, no progress on getting a specialist ME clinic for the Kirklees and Calderdale area, which together have got a collective population of over 500,000 people. During our negotiations, we've been faced with a litany of excuses from the ICBs as to why we cannot have a specialist ME clinic for this area. It should be added that any specialist clinic for this area would require specialist training of the health professionals involved in its staffing. And at the moment, the vast majority of health professionals in this country have little or no knowledge of ME. And I'm just going to add this into my speech. It'll only take a few seconds. I've been to A&E HRI twice in the last year. Not one of the staff knew anything about my illness. I was in a great deal of pain and I had to beg the staff to put me in a quiet dark room to get out of the anarchy which was going on in A&E reception. I've seen a neurologist at Halifax recently and the neurologist also knew nothing about my illness. He said that I knew a lot more than I did about our illness, which I think is outrageous. He was unaware of the NICE guideline and the new Department of Health Care Plan. And in our negotiations with both Kirklees and West Yorkshire ICB, we've been pressing very strongly for GPs and hospital staff to have a basic understanding of our illness. Otherwise, those health inequalities and putting people's lives in danger is going to continue. The NHS has produced 3 e-learning modules for all health professionals to access as part of their CPD. Unfortunately, the Labour government will not make these e-learning modules mandatory for health professionals, which is a major problem for us, for people with our illness, because we routinely come across health professionals across the board who know absolutely nothing about our illness. And Kirklees and Calderdale ME Support Group today is asking for the support of Kirklees Council in our campaign to obtain a specialist clinic for people with our illness in this area, which there'll be thousands of people in this area who've got our illness. We're also asking for the Council to help in our campaign to get health professionals in local hospitals and GP surgeries to be trained and educated so they have at least a basic understanding of how to care for people with our highly complex neurological disease.
Thank you for the deputation. You've given us a very brief insight into the problems that people with ME face. What I would like to do is invite you to attend an informal briefing session with the committee. This can be done online so that you don't have to travel into the town hall. And once we've had that further briefing, we can then look at what actions that we as a committee could take. That could be writing to various NHS bodies or actually putting it on next year's work programme. But thank you so much for attending. Thank you. If we can move on then to item number 7, which is the 0 to 19 commissioning is access to care, and it's looking specifically at the role of health visitors. If you could both introduce yourself as well, that would be good. Thank you.
Good afternoon. My name's Cliff Dunbavin and I'm the Head of Operations for the Starting Well division, which is essentially all things children's services at Low Carla, and we're the provider for the Kirklees 0 to 19 Healthy Child programme. So I believe that whilst I'm going to talk about the role of the health visitor, there's a particular lens on the antenatal, the visit, I think I'll go through that, and the presentation has been drafted to answer that question. But if I may, I'd also like to give you some further information about partnership working and that broader offer in Kirklees. Before I start on the presentation, what you might not be aware of is Locala has successfully been nominated as the provider for the new Healthy Child programme, which starts in April of next year, and we're currently we are the incumbent, but we're presently in the mobilisation stage, and only this morning did we have a meeting where we're starting the negotiation around what we proposed in the new model and what the Commissioner would like us to deliver. So it's not set in stone, it is very much a partnership arrangement around how we deliver things in Kirklees going forward. So if I may, I'll turn to the presentation. If we can go to slide 2. And this is around the role of the health visitor. And please be comfortable about asking any questions as we go along. So the role of the health visitor, a number of areas. So first of all, to lead on the Healthy Child programme. Now, the Healthy Child programme sets out a number of different requirements. There are several mandated contacts that are required, and you'll see from the slides further on, and particularly in slide 7, it describes what those mandated contacts are. In addition, with the new contract that's coming forward, there's also an additional contact, which isn't described in here, which is a 3 to 4 month check, which has been brought into the new Healthy Child programme in Kirklees. So that's around to lead on the Healthy Child programme. Secondly, to promote health, well-being and child development, working with new parents and parents-to-be. The third point is to support parental and infant mental health. Fourth, to identify need early and provide targeted support. So there's definitions within there around what the health visitor will be focusing on in those assessments. Fifth point is safeguarding. Safeguarding, would be no surprise to you, is a big component of the role of the health visitor and takes up a considerable amount of time. But I must say the safeguarding in Kirklees, particularly around children's services and the role of the health visitor, is really robust, really robust. Sixth point, to work in partnership across Kirklees. The way that Locala delivers the Healthy Child programme in Kirklees is absolutely not in isolation. We are not a standalone service. We're very much around working with the wider partners. So that's from the voluntary sector to commission services across Kirklees, the local authority, and I can go into detail later if you wish. Maternity services, the acute trust, it's very much a partnership approach, and that's the only way that we can deliver an effective service to young people and parents and the family. The seventh point is to promote equity and reduce health inequalities. There's been a real lens on this over the last year. Is instead of having that universal offer, everybody gets the same thing. We know that there are certain areas within Kirklees which need a particular focus, and working with our intelligence leads in Locala and also with the local authority intelligence leads, it's around what is that data telling us and how can we tailor our offer to that community. So there's really real focus on that, and we'll see that playing through in the new contract. And the eighth point is community health leadership. We are absolutely a leader in this, and we want to be around the table, and we are around the table at all. Anything around the child, we want to be around the table and be part of those discussions. So, if we look at the focus on partners through the antenatal and postnatal journey, it is a fully integrated service. There's a list of partners there who we truly integrate with, and that's Change, Grow, Live, substance misuse services, Home Start, Fresh Futures, local services to you, anti-PAMS, GPs, mental health services. Really well integrated, really good relationships with all those services across Kirklees. Peer support and community champions, really well integrated there and work really closely with them. I can come on to what's in the new contract later if you wish to ask me about that, around how we enhance that offer. So moving on to slide 5, and that's the role of the health visitor in the antenatal care. So health visitors clearly play an integral part in delivering the Healthy Child programme. The focus around the antenatal is around 28 to 32 weeks. And here what we're looking at doing is building on early relationship with parents, building that trust with parents, so the parents know who the go-to person is, having named health visitors so they know they're not just going to a faceless team, faceless organisation. They know who they have a named health visitor that they can contact at any point. So it's not a case of waiting for those mandated contacts to happen. They can contact that health visitor at any point through their pregnancy cycle and post-pregnancy. There's a holistic assessment conducted, which covers off areas there. As you can see there, preparing for parenthood, infant development, safe sleep. Been a real focus over the last year around safe sleep. I've had a colleague who's based in Calderdale, who has been delivering across Calderdale and the Kirklees footprint around safe sleep practice, and that's to multi-agency, to the police, to partners. That's been a really, really successful programme. Parents' mental health, which is a big issue, and there's lots of support there. Again, the only way that we can effectively deliver that is by working with our partners across Kirklees. And it's about identifying vulnerabilities in those families, and just said there, coordinated care, which I've mentioned before around how we work closely with partners. So we move on to slide 6. So this is around the antenatal contact. So what's the purpose of it? So it's to identify family health, well-being and social needs early, detect vulnerabilities or risk and support, and make sure the support is in place before birth, build on trusting relationships, provide information on newborn care, feeding, safe sleep, bonding, infant development, support parental, emotional and mental health, promote healthy pregnancy and help reduce health inequalities, signpost to local services and community support, and then finally coordinate care with midwives and GPs to support the family. So slide 7 does describe the Healthy Child programme mandated contacts, and just to repeat what I said earlier, there is a 3 to 4 month check in addition to that, which will be coming on board in April. And then slide 8, 9 and 10 just gives you well, it describes the progress that the low-cala 0 to 9 service has made. So there was real scrutiny on the, should we say, less than palatable achievements of the antenatal contact a year ago, and you can see how that's really improved with really focused interventions, working with the family, finding out what works for them. So is a face-to-face visit what they require? Would they prefer, so for instance, a family who it's not their first pregnancy, but has had no issues with child 1, child 2, is a video consultation the best fit for them? So we've employed that over the last year, and our contacts have certainly increased. Slide 9 describes how we map in Kirklees against the national data, the West Yorkshire data and the national data. The thing to bear in mind with this is the national and West Yorkshire data is a year behind. So we are comparing this year with Locala's achievements against last year with the Yorkshire and Humber and the national data set. And then finally, the 2 and 2.5 year reviews. Whilst the focus on this is around the antenatal visit, it's worth noting that nationally there's going to be a real focus on the 2 and 2.5 year reviews, and this is a particular focus on school readiness, which can give you the assurance that there are many meetings going on at the moment, and we're lining ourselves to make sure that we are going to be addressing that school readiness and making sure that the children have the best start in primary school that they could possibly have. And it starts at the 2 and a 2.5 year review. So I'll pause there, the information's there, and if anybody wishes to ask any questions.
Thank you. Councillor Monroe, did you have a question?
Thank you. So thank you very much for your presentation. So just a couple of questions at the moment. I noticed that the role of the health visitor follows a national Healthy Child programme, but is delivered through a fully integrated 0 to 19 service. And I note that the purpose of this report is we're receiving an overview of the role of the health visitor in Kirklees as part of an assurance on 0 to 19 commissioning access to care in Kirklees, which includes the role of the health visitors. So obviously there needs to be a big focus on 0 to pre-antenatal to 5. I completely understand that, but there's no reference at all to anybody who's older than 5. So it would be interesting to know what you're doing, what happens in relation to older children. And I'd also like to know, in relation to antenatal contacts, that's gone up to 75%, but still, we're still not making contact with a further quarter of pregnant women, which is a concern. We are aware that, I am aware that there's another programme that I'm funding in my ward for women who say they don't know anything about antenatal. They're not given the information at the antenatal stage at the hospital. They don't really know what's going on. And we've funded an individual programme in my ward to help support women. So women are clearly falling through the net, and giving birth has become more risky for mums nationally. So clearly that it's important that you're going to catch those women. So what do you plan to do to get to reach those other 25% of women that you're not actually reaching at the moment?
If I can just interrupt there, the remit of this meeting was specifically to look at the role of the health visitor.
Well, what is the role? How is the role of the health visitor? What do they do? What are they doing to get to those women who...
No, my is from your initial question where you were then asking what happens age 5. The reason the report doesn't actually state anything from that, it was because the questions were specifically the role of the health visit. It came out of the actual reports that we had on the initial commissioning, where we were looking at sort of, well, hang on, why are health visitors doing antenatal checks, etc. And that was what today's meeting was about. It wasn't for over 5, so that's why there isn't any information there.
Okay, thanks
but
for explaining.
Did you want to answer
the second question, please? Okay, what are you doing to reach those women who you're not able to reach at the moment? Thank you. What's the health visitor doing? Okay, yes, thank you.
Okay. So in answer to the first question, so the 0 to 9, so 0 to 5 health visitors remit, beyond that school nurse remit. And there is no doubt that with the, I'll say the current contract and the previous contract, the weight was loaded towards the health visitor contact, and the school nurse was pretty much the Cinderella role within that contract. There's been enhanced offer in the school nursing space, and there's been an awful lot of integrated working. So, of course, the family hubs, integrated working seamlessly with Jackie Beaver and her team in early support. integration with the new gateway, with having school nursing representation in the gateway. That's the single point of access for Kirklees and families. So in there, direct access, clear, rapid signposting there. Working with our partners in the family hubs, Fresh Futures, local services to you. So there's been a real increase in activity in that school, should we say school nurse or the over fives offer. Again, I come back to the school nurse service can't do it alone. It's got to be very much a partnership approach. And I think the catalyst to that, and the thing that's going to support that, is the new family hub programme. Yeah, is really joined up working. So, thank you. So in terms of the antenatal contact, we continue to work with parents and to target those ones that we're not hitting. You're absolutely right, there is a number that we're not hitting. And it is around early, getting in there early, and if we're not getting the response, is keeping on with it until such time as we do get a response from the family, and we're so there is that offer. We have tailored the offer. In terms of the promotion of that, we've recently brought online a 0 to 19 app, which has got information that's been signposted to all parents to be. That gives information around the role of the health visitor. The website, the Locala website, has recently been redesigned with clear information about the role of the health visitor. So that engagement of this is what a health visitor does. Engage, because it has been about engagement today. Yeah. Yeah. Thank you.
Are there any other questions from the panel, Kim?
Yeah, I just wanted to know, well, two questions really. There's a lot, looking at the slide presentation, there's a lot of information on digital access and digital resources, but how does that work with people where English may not be the first language? You're smiling, so I'm sure you're going to tell me a really good answer. And also, my second question is around the role of the health visitor in those children aged between 30 months and up to the age of 5. What role does the health visitor have with those children, and are they involved in the child measurement programme, vision checks, hearing checks? I'm not sure whether they still go on, but certainly the child measurement programme, is that something health visitors are going to be involved in? Because quite clearly there's different visit schedule and checks up to the age of 30 months, but what happens between 30 months and age of 5? Thank you.
So I'll answer the second question first, and the answer is yes. They are fully engaged in that, and again that comes to that making sure that 2.5 year that everything is in place and that those checks are carried out, so that there's no surprises when it comes to that 2.5 year check. We are working with really strengthened our working relationships with early year settings. So the shift will be that presently the early year setting will do the ASQ assessment in a lot of cases. The new agreement is that the health visitor will carry out that. But what we don't want is when it gets to that, when it gets to 2 years, what we would expect, and there's been a lot of work with the early year settings on this, is that issues are flagged up, so that when it comes to 2.5 years and the health visitors carry out that assessment, we know what's coming through, so we can really focus and target our interventions there and our assessments in there. Instead of just carrying out an assessment, we know what's coming through because it's been flagged up at that 2 year. In answering your first question, when I mentioned earlier around that lens on what does that community need, where there might be language barriers, yeah, digital isn't for everybody. We appreciate that. What we have done is we've promoted and employed within the service particular language speakers who will work with those community settings. So, for instance, Batley, Dewsbury, we have a number of Urdu speakers out there who can engage there. The new service offer as well also has, so several years ago there was a pot of money which we secured. It was a 3-year program for starting well, and then unfortunately the money ran out and we had to pull that back into the service, but that dedicated resource and dedicated resource out in those communities, working with communities and the community assets really paid dividends, but it was pulled back into the service. With the new contract, we brought that back in. So we've got 2 colleagues. One will work in the north with the family hubs, and one will work in the Huddersfield area. And what they will do is they will work in partnership with the family hubs coordinators. So that's the offer that we've put on. They will work with the community, they will be dedicated to that community, and they will understand what that community needs. And if it is language barrier, that's how we will put a different offer in that area to what we might have down in Kirkburton. So that's okay. Thank you.
Councillor Firth.
My question is, clearly, the baby's a first concern, but reading this slide, it mentions maternal mental health, and not all women that have had babies cope very well. What do you put in place? Because sometimes that could put the baby at risk as well, as you well know. So what do you do if the health visitor finds something really untoward, very disturbing? Is there a method of reporting those concerns, whether it be to social services or even the police, if necessary?
Yeah, so the health visitor will be skilled to a certain extent, but they won't be a specialist in that area. What they will do, they'll be able to recognise and they will be able to signpost on. So that's either through their relationships that they've got in their community settings, or through the gateway, is rapid referral, a timely referral through the gateway, and then through the gateway making sure that they're getting access to the right level of care. In the new model for Kirklees, well, shall I just say that unfortunately Kirklees weren't successful with the family hubs funding previously. It has come online now, and there's going to be 3 years funding, but unfortunately Kirklees weren't successful. You didn't quite hit the criteria for attracting that funding. Calderdale, on the other hand, did. And what we've employed over in Calderdale, it is relevant. This what we've employed over Calderdale is a dedicated team around perinatal mental health, and in there we've got psychologists working in that team. Whilst it isn't in the new bid, we've got a dedicated resource over there that will be doing some education programs in Kirklees. So Locala will be lifting that colleague out. If we're educating our workforce in Calderdale, the workforce in Kirklees will also be educated as well, because we're one and the same thing. So whilst it's not being paid for in Kirklees, there's that resource that we can tap into. And this is a colleague who joined us last year from Swift, who has worked across a number of national organisations and is right there at the top. So I'm pleased to say that in terms of that early identification and improving the knowledge base that we've got, we're going to tap into that resource shortly.
Thank you very much.
Hi, got a couple of questions. Can I just clarify then, in terms of actual visits that are guaranteed to parents with their child, is that 5 across 2-3 years? Home visits? Sorry, that was my first question. Do you want me to carry on, and then you can? And in terms of safe sleep, do health visitors actually work with parents to get a safe sleep programme in place, or do they just provide information? So is it just, here's a leaflet, or you can access some help via this app or something, or do they actually deliver a programme of safe sleep? I noticed on your graphs that there were, sorry, we're on to point 3 now. I noticed on your graphs that some of the percentages were lower than the rest of Yorkshire and Humber, and I think maybe in some cases than the rest of England. So it was just kind of your response to that really, and why is that in that way? And then the last point was to ask you, what are your sort of aspirations for the future? If you were to say in 1 or 2 years' time, how different would that look? What would be different for parents and their children? Do you want to go through it again?
Just give me the pointers. I think I've got them all, but just give me the pointers.
I think the first one was, is it a parent's guaranteed 5 visits in
6.
up to 3 years?
6. So you've got the ones that are listed there on slide 7, of which there are 5, and then we've also got the 3 to 4 month, which is coming on board. So that is the minimum. If again, having a named health visitor, if further interventions are required, then all they need to do is contact, or indeed, if the health visitor assesses the family as being moving out of the universal criteria towards more targeted interventions, then that care will be delivered as well. So there'll be more than the 6 visits. All depends on the thresholds that the family or the family needs. Yeah. Next thing about the safe sleep. It's not a case of here's some there is information on the website, there is some information on the app, but in terms of that assessment in the home, it is that working with the family, it's looking at the bedroom, it's looking at mattresses, it's looking at the environment that the child's going to be sleeping in. So it is that physical assessment, not just here's some information and I'm off. Is that?
Sorry, so when you say the term safe sleep, you just kind of mean the right environment. I was sort of thinking about concerns that when babies don't sleep and then they co-sleep with a parent, which some people advocate, some people don't because of the risks. Yeah. So if a baby isn't sleeping, obviously that can then lead to other issues for the parent, mental health of the child, etc. It's more than just have you got the right mattress.
So it's So again, it's about working with the parent to employ certain strategies, and then also signposting. If there is a need there, why isn't the child sleeping? Is it the environment? Is it other issues? And then working with GPs, paediatricians, etc., the midwifery. Whilst yes, they've handed over, they've got direct access to acute care. So it's about if there is an issue there, it's about ownership of the health visitor. Because if the health visitor isn't owning it, who is owning it? But it's about and then it's about that coordination of the care that the parent needs. Okay. Sorry, what was the third?
It was just where will you be in, what will you see different in 1 or 2 years in terms of, but specifically in terms of what a parent or child would see differently, rather than rather than, because I understand from your presentation that there's a lot of investment in working with other organisations as part of a team and to have a information sharing, etc. I'm trying to make the link between that and what an actual parent or child will see as different, and because I guess the prevailing thought is that health visitors only come to people 5 or 6 times over a 3-year period. And I'm speaking from one other person's experience of this, not mine, but that it's a bit isolated unless you are recognised as being in a severe category. And that might be completely okay. I'm just trying to clarify whether that's
I think you're right, and I think to be fair, I think that's through, and it's no, I've got my public health colleague to my right. It's through a lack of investment over the years. That has changed now. There's been a shift with the council, which we're delighted to see, with greater investment in that contract. It has been at one point. It was there was a lot of money flowing through to 0 to 19 services. Then it was stripped out, and I think nationally that's what you're seeing playing out. I'm really passionate, and this is being driven through. When I talk about partnership working, it cannot be a standalone service. What I'm really passionate about is there are named people. So that parent, that mother, has a named person. What I then want to see, and we're seeing it play out, is I don't want to see a referral over there. I want that parent, it's handovers. It's I want you to see my colleague. I don't care who that colleague works for. It might be Mid Yorks, it might be CHFT, it might be Change Grow Live. It's a handover. I want you to see my colleague. In the parent's eyes, it's a massive team that's supporting that family. Not I'm handing you over to there, and then the health visitor loses sight of what's going on over there. They've got to own it, and they've got to know exactly what's going on to support. But the health visitor stays close to the mother, and the mother knows that that's their point of contact.
And is that, would you say that's now, or that's something?
It's we're already seeing that. I think Lucy could probably advocate for that. That our partner Locala is driving, and I am driving a lot of the partnership working. Partnership working, getting the key people around the table. We're all saying the same things. How do we move this forward? If we wait for commissioners to make the decision, we need to be shaping it and saying, here's what we can deliver, and we're all saying the same thing. So if I can describe that round the table, the Gateway was a prime example. It needed to change. What did we do? We got education round the corner, round the table, we got the local authority, we got health, we got everybody around the table. We came up with a model, and in no time at all, we had that model in place. It was embedded. And I think we're seeing, I've been around for a long time, and those days of, well, I'll do it if you give me enough money for it. We don't want to do that. It's nothing to do with us. That's changed. Believe me, that is there's been a massive change. You get the partners around the table, they work it up together because they see the benefits from working in partnership. There's true partnership working.
So what will parents see different? So what will parents see different?
Parents will see that somebody who's coordinating that care on their behalf. We're not saying, I'll do a referral, you'll have to chase it up with so-and-so over there. They'll be in touch. And then somebody doesn't get in touch. And the parents think, well, what's happened to that referral? No, it'll be owned by the health visitor. Okay. And yeah. So, for instance, like I've done when I was a clinician, if you don't hear anything, let me know. And the parent knows they've got a named health visitor, a named service that'll own it. And to be honest with you, it's the only way that can we deliver effective services is by that joined up working. Sorry.
Thanks, Cliff. Just to add to that, in terms of the difference that parents will see, I think one thing to make clear is that the 3 to 4 month contact will be kind of mandated within the new service. So that will be a big difference to how the service operates now. So at the minute you will see a health visitor between at the 6 to 8 week visit, and then you won't see one unless you need one until 1 year. And we recognise that's obviously a really long time to go for a parent, between 6 to 8 weeks and 1 year, when you're thinking about weaning and all of those kind of things. It's a massive change for that child and that family. So I think that will be quite a significant difference that families will see. The other thing that we've built into the new contract, which we've tried to be much stronger on and invested more in is the visits at home. So mandating that all of the visits will be at home if that's what that family wants, because that's not always been the case. But what we want is for that proper offer to be at home if that's what is wished from the family. There is a community offer as well out in the community, but also we wanted to make sure that families can access that at home as well. So just to add that.
Can I just ask, did you answer the question on the graphs? On the fact that Kirklees appears to be lower in some cases than Yorkshire and Humber and England?
Our reporting is scrutinised within an inch of its life by the Commissioner. I can assure you that our reporting is accurate.
And by that, do you mean that it is less than Yorkshire?
I've got to be careful what I say. When I look at how some organisations are performing, when you look at the staffing model, you do wonder how they're achieving that. When I see my team flat out. I can't answer on behalf of how other organisations are reporting. I can answer on behalf of how Local is reporting, and we've worked tirelessly with the Commissioner to ensure that our performance reports are fully scrutinised, and where they're not delivering the outcomes that the Commissioner requires, we're changing our delivery model to address that, and I think that's how you're seeing it play out.
I think just to add to that as well, what you can't see, I think, on what you've got there is the journey that Locala and ourselves have been on over the past 3 years in terms of improving all of the mandated contacts. They are significantly better than even when we came back in the summertime. That's not to say that we're kind of resting on our laurels and accepting where it is, but they are so much better than what we used to because of that much improved performance focus between the provider and the Commissioner. We meet monthly with the provider as well as having quarterly performance monitoring meetings. We don't just look at the hard data. We've also Locala have conducted deep dives. So where, for example, there's a mandated contact which we know is underperforming, like the antenatal contact, Locala have gone out and spoken to families and parents to understand what's going wrong here, what's not happening. So, for example, with the antenatal contact, we found out that families were quite I suppose a bit confused between the role of a midwife and the role of a health visitor, because you see them both at a very similar time. So you've done a lot of work around that, haven't you, about helping families to understand the difference between a health visitor and a midwife. And we're also hoping that the fact that all of the mandated contacts will now be in the home going forward with the new contact, that those visits will continue to increase.
May I just add to that? Add a little bit of context to my comment earlier around other organisations elsewhere. We did a deep dive probably about 18 months ago where we compared where we were in terms of caseload size and investment in 0 to 19 services, and Kirklees was down, well down. Caseload size was up. So, and that's why I was really pleased to see the investment that's been made in this new contract going forward. There has been a shift. It has been under-resourced. That's no fault of the local authority, but it has been under-resourced. Other areas are in a more favourable position financially, and I can compare to Calderdale, where we all deliver services. If you look at the caseload size, that's much less than what it is in Kirklees. And that's down to investment in that service over there. But just to add to what the commenter made, if you just focused on the mandated contacts, you could probably hit them all. If you're looking at a more holistic offer and that partnership working and being truly integrated out there and investing some of your time in building resilience in communities as well, you're probably not going to have that second, third visit to ensure that you're hitting that antenatal, whereas other areas may well be focusing on that because they haven't got that joined up working. Okay.
Thank you. Councillor Thirth.
Thank you, Chair. Can I ask about the numbers of antenatal people, health visitors that you've got on the books, and what are you like for recruitment and retention of those people?
So there's been a drop. So birth rate, I think, if we look back, probably 18 months was around about 5,200. I think it's come down to about 4,748 now. So it has reduced. In terms of recruitment, recruitment is a national issue. There simply aren't. If we're looking at band 6 qualified scuppers, public health nurses, they simply aren't out there. And if they are out there, they're not moving around. So you're essentially poaching from other areas. We have had some success where people have moved into the area and they're looking for jobs. But what we have done over the last 4 years, 5 years, is growing our own. So we do invest. So what we found is really paid dividends is you can recruit to band 5 nurses. So people are paediatric nurses, are you working in acute trust, who've got no pathway. So what we've done is we've recruited 2 band 5 nurses. Now, they can carry out some of the activities, some of the mandated contacts, if they wish to remain as a band 5. But what we also do is if they wish to progress once employed by a locala to become a scuppern, a band 6, a qualified health visitor, a qualified school nurse, we invest in that and we support them to develop. And that's really paid dividends. So there are students, we have a student programme and we take 4 students a year. And you would hope that they remain with us, so they come in as students, and so these are university students. That's been in place for a long time. But recruiting in band 5, some other areas, and then give them the opportunity to develop has really paid off.
So obviously, the situation is, from your point of view, very healthy.
In terms of growing our own, which is how we refer to it, definitely, yeah. We're confident that we've cracked that, because it was a big issue about getting. We'd have had adverts out for month on month, and nobody was applying because, as I say, people just weren't moving around. And of course, we've had a cohort of colleagues who can retire at 55, and they are doing. So you're losing that really experienced colleagues. That is starting, that at some point that opportunity isn't there anymore, or it won't be there anymore. But that's the reality. People have been retiring early and people haven't been coming through. So yeah, we are confident.
Thank you. That's...
Councillor Munro.
Just one question. Just what do you feel are your biggest challenges providing this service going forward? Sorry if that's taking you by surprise a bit. What would concern you, or if you can tell us, that is, I mean.
I guess things that are not under our control, in able to shape, and that's around national issues like poverty, and which are clearly not under our control. I hesitated in answering that because I am, and it's not through arrogance, but as I say, I've been around long enough. The shift and the mindset and I gotta come back to that joined up working is so much better. In fact, it's wonderful. It really is to see it, to get around the table with like-minded people and work up a model. There's been a massive shift in mindset, and it's supported by senior management, by the commissioner, because I've been fairly vocal, is we look at the provider-commissioner relationship as not a hierarchical thing, but it's a partnership. The commissioner has a difficult job. We have a difficult job, and the only way we're going to get through that is by working together.
That's good to hear.
Yeah.
Are there any further questions from the panel?
Just a really quick one. I'm just interested to know the home visits, is that for all children or just the first child if they choose to have a home visit?
If they choose.
If they choose,
So it's down to choice. What we learned was you can give choice. So what we did a while ago, probably about a year ago, 18 months ago, we gave a choice. What would you like? I don't really want you to come into the house. We'd like to come to a health centre. And then guess what? They didn't turn up. So there's only so much choice, and we learnt our lesson from that, and our figures just weren't where they should be. So by bringing in that hybrid, that virtual offer, so you can see things, you can see environment, yes, you can't see it as well as if you're in the house.
But they can have
that
home visit.
Yeah,
if
and you
it's
can
a
build that
second, third,
relationship.
whatever
Before
yeah.
it was just somebody at the end of the phone.
Perfect.
Could have been anybody.
Yeah.
So we brought that on board as well.
Thank you.
Can I just expand on that further? Is obviously for some sort of parents or carers, they might deliberately not want a home visit, and there could be safeguarding issues. Would all of these mandatory visits be done in person, maybe at sort of GP surgery, community health centre, or things like that?
So the situation that you highlight is a concern. So that again is about working with who's been involved with that family. Are there any safeguarding issues? If there are safeguarding issues, they automatically become a targeted family, and therefore that mandates that a home visit, regardless of whether the parents want that, it's about the child. So that becomes a mandated home visit, and there will be that perseverance.
Thank you for actually clarifying that. So it was just sort of like, you know, you hear so many horror stories in the media where children are not actually visibly sort of seen, kind of thing, and it's good to know that sort of obviously there are discussions with other organisations that are in contact with the children, and if need be, they will be seen at home with their parent or carer. Is there any other questions people want to raise? If I can just thank you for coming today to the committee to give us a better understanding of the role of the health visitor, and especially it's good to see the joined up working that is happening, so it's multi approach. I also note the work that is being done on to include people from various different ethnic backgrounds within to take up the service, and also the work that has been done to try and improve the contact rate at sort of the different mandatory visits. And it was good to actually clarify the thing about the antenatal visit, because that was the one thing that actually, like, why are you going in there? And obviously I realise now that if I was asking that, a mum-to-be who's probably sort of got the midwife coming in is probably also wanting to know why. But it's good to see the actual improvement in those in the mandatory contact visit, but also to show that it's not just about those 5 or 6 visits, that there are other inputs from health visitors. So thank you for coming today.
Can I just say, I think it's difficult at times to describe, and health visitors are very passionate about their role. It's hard to describe that it is that holistic assessment. It isn't just going in and ticking a box and saying your child blah 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 blah. It is about looking at that whole environment and what's going on with that family.
And I do feel that today you have actually given us a good oversight of the holistic approach by the actual health visitors. So again, thank you for coming.
Thank you, and thank you for your questions.
I'll just move on very quickly to the last item on the agenda, which is the work programme. And that is just to say that we will be having an extra meeting in January where we will be looking at the CQC report for Kirklees and what action the teams is going to be taken. If there isn't any other business, I'll close the meeting. And thank you for attending.